case. This is an ear infection. In fact, I've seen this patient on a number of occasions, and both of his ears are always infected. This is a chronic problem, and all things considered, his ear at the moment doesn't look too bad. This is probably the best I've seen it. There's a little bit of pus, and there's obviously lots of dead skin down there, but all things considered, it's okay. There's a little bit of swelling, there's a little bit of inflammation, but normally both ears are full to the brim with pus, basically. And how do I know it's currently infected? There's, aside from the obvious signs, there's a little bit of not too bad, but ear infections have, probably audiologists and nurses and doctors watching this will know what I mean, but ear infections have a very, very distinct, unexplainable smell. It's like nothing you've ever smelled. And that's one of the, I suppose, diagnostic criteria, really. But the object here, like whenever we do an infection case, is to get rid of as much dead skin and muck out of the ear as possible. Not just to make the patient feel better, but also to help the treatment along a little bit. So if you just leave lots of pus and dead skin in the ear, the infection will come back. It's not really good or helpful to take medication when there's a kind of a soup of bacteria in the ear, merrily eating away, feeding on that dead skin. It's just not going to work. And again, just to comment on what you're seeing here, the first half of this video is, contains a lot of faffing around really before good action starts. And what I'm doing here is really just kind of getting a feel for how to best approach the case. And again, that's why I'm kind of just going in very gently and kind of seeing what I can prize away. Ultimately, sodium bicarb drops are going to need to be administered. So some of you are probably wondering, well, why do both his ears get infected over and over and over again? There must be a reason why his body isn't fighting off the infection. Why is this happening? And we're not entirely sure. So, we've gone through the kind of, this patient has gone through the classic cycle of, ear cleaning and debridement of skin, medication, debridement of skin, medication, debridement of skin, medication, and so on, which should work, but it's not. And I think it might have something to do with the medication that he's taking. So he has a few long-term health conditions, and one of the medicines that he takes a lot of all the time is, I can't remember the name of it, but the long and short of it is that it interferes with the production of prostaglandins in his body, which has nothing to do with his prostate, but it's just, that's where the prostaglandin molecule is first discovered. But prostaglandins are everywhere in your body, males and females, and they're very important in the regulation of inflammation. So prostaglandins will be very helpful if the cells in your body are damaged, or you've got an infection. Prostaglandins will be there, and they help your blood vessels dilate, which helps white blood cells get to the area and so on, and ultimately helps your body fight infection and repair damage. And if you've ever taken ibuprofen or aspirin, that's basically how they work. They interfere with the prostaglandin production in your body. So, but of course that's only a temporary thing, right? Inflammation is in many ways a good thing, just like pain is a good thing, itching is a good thing, dilation of blood vessels and redness and so on. It's all good stuff, because it's really your body's way of dealing with something. But if you're taking lots and lots of medication which constantly is interfering with the release of prostaglandins, then that might open the door to these repeat infections. So that's a possible theory. And it's the same kind of principle behind diabetics, having a compromised vascular system. So diabetes damaging the small capillaries in your body, that in turn hampers your immune response. So there's lots of sodium bicarb here. And at this stage I thought, well, sod it, I've got to do something to kind of speed this along, because I was making very little progress up to now. And the sodium bicarb, I let it sit in there for maybe a couple of minutes, I think. And the sodium bicarb, which is basically just, it's a water-based drop, which releases carbon dioxide when it touches things, acidic material. What it's going to do is just give me a little bit of purchase, help me lift the skin off this eardrum. So this doesn't really look like a recognisable eardrum, right? But watch what we do here when I catch it from the bottom. And what we're going to do here is peel off this layer of skin from the eardrum. I'm just trying to find the right place. Finding the right place. That's part of the magic. You can see underneath that kind of bluish skin. That's the eardrum. So that means it's come off, obviously, because this patient does have an underlying age-related problem, so that's making the whole thing worse. So the eardrum actually looks quite nice, it's pretty good. And now what we're going to do is, I mean that's the main part of the job done, so to speak. But now what we're going to do is we're going to try and just get away as much dead skin as possible. Again, not just to make the patient feel better, but also we're just trying to give them the best chance of getting rid of this sodium bicarb going in. And again, this is just going to help him suck up and sort of peel away all this dead skin. And he's actually, when you're trying to peel stuff off the ear canal, well, it is actually very, very difficult because we're that deep in the ear. So if the outer third of the ear canal, which is nice and squishy and cushiony, there's cartilage, there's fat, and so on, it doesn't really matter if you kind of, scrape around the suction probe. It's not going to do that much damage. But when you're in the inner two-thirds of the ear, it's very thin skin on bone. We're talking 10th of a millimetre layer of skin on bone, which is really, really sensitive. It's very, very uncomfortable, very painful, in fact, if you knock against it or put too much pressure on it. It's not too difficult to lacerate the skin because, again, it's just bone. There's no cushion. Now the keen-eyed among you may kind of see that as I'm trying to get this little bit of dead skin off, there is a little bit of a cushion effect due to swelling, due to inflammation. So, and the reason for that is that, again, although the patient is taking this medicine to inhibit prostaglandins, as I mentioned, there will be other chemicals in the future trying desperately to get inflame the area, trying to dilate those blood vessels. So there is some response. When your capillaries become dilated, fluid leaks out into the tissue. That's what we call edema. So that creates a little bit of cushion as I'm kind of pressing the suction probe. So that gives me some remit, but again, I can't dig it in there, if you know what I mean. I can't just kind of scrape the suction against the wall of the ear canal. And again, minimal pressure. Very, very careful minimal pressure. Again, just trying to get this. And again, bacteria and fungi learn to colonize the skin, which is called biofilm. So a biofilm is a big biofilm, which you will have all seen because back on your teeth is biofilm. When you think about biofilm, it's a very big problem because when bacteria colonize in a wound, then they will exude this slime which protects them. And if you've ever seen like a leg ulcer or a wound which is oozy and has kind of like a gel on it. That's usually biofilm, and that's the bacteria creating a colony for themselves, which protects them from medicines, trying to kill them, and allows the bacteria to actually share genetic information, which is one of the reasons why bacteria become resistant to medicines. You can just peeling this, it's sitting here at the top, but we're nearing the end of the procedure now because the patient is getting a little bit jittery. And again, there's no anaesthetic here, so we're really just kind of relying on the patient's will here, but fairly nice looking eardrum, I have to say. Again, there's inflammation there, but for all things considered, it looks quite nice. Just peeling this last little bit around the attic. So, and by attic I mean, that's what the term used to describe the area above the eardrum. So, and broadly speaking, you know, we tend to think of that part of the anatomy in three sections. So you have the main part of the eardrum, the kind of lower 2/3 is the pars tensa